Good afternoon, everybody, and thank you so much for being here. We are Group 2, and we're going to discuss universal health coverage of Malaysia and the Philippines. Ada is here, Mike Lazarte, Adi, and myself, Michael Weinberg. We wanted to start off with a quote that we believe is really crucial to this conversation. So, the right to health is fundamental, universal, and irrevocable. And that was said by the WHO in 2018. Here's a brief agenda. You're welcome to look at it if you like, but we're going to go ahead and get to it. So, if we look at what universal health coverage is, it's defined by the WHO as ensuring that all people have access to needed health services, including prevention, promotion, treatment, rehabilitation, and palliative services that are both of sufficient quality, effective, and also ensure that the services don't expose the user to financial hardship. The Philippines Universal Health Care Act automatically enrolled Filipino citizens in the National Health Insurance Program, and it also prescribes complementary reforms in the system. Malaysia also has a universal health care program that is funded by the government and provides low cost to no cost services for all of its citizens. If we go ahead and look at Malaysia as a country and at their demographic profile, we see that the total population is about 32 million people with an annual growth of about 1.29% in that population. We see that the GDP per capita is about $9,500. That's a really important number that we're going to come back to. And then the life expectancy is about 75 years old. Total health expenditures as a percent of GDP is about 4.2%. And then expenditures per capita about $455 per person. And then government expenditures as a percent of the total health expenditures is about 55.2, or just over half. If we move into some of the health system dimensions, we see that Malaysia's system is very advanced and funded by the government through investment in improving medical infrastructure for citizens. Malaysia's pioneered access to universal health coverage starting in the 1980s, with improvements in implementation taking place in the 2010s. Malaysia has a two-tier health system where citizens have access to public universal healthcare and private healthcare systems. So the public system is paid through general taxation of income, with government funding to provide low-cost, universal, and comprehensive services to citizens. Public healthcare is also the cheaper option, but citizens also experience long wait times, overcrowding due to the high volume of patients who use the services. But on the other hand, the private hospitals offer faster services and more doctors, but it also comes at much higher out-of-pocket prices for the patients. Additionally, the medical staff and facilities, the quality of the doctors, the surgeons, and the other medical staff, they don't really differ all that much between the public and private hospitals. The hospital equipment is also of high quality, and they have very high standards for regulatory aspects. And then the costs associated with the treatment, this has been rising generally in the country, with more patients moving from private hospitals to public hospitals. And so that is, providing for an additional burden on the government-run public option for patients. If we look at the Philippines, some of their stats, we see that they're at about 106 million people with a slightly higher population growth annually of about 1.5%. We come back to this GDP per capita number, and they're just below $3,000 per person. If you remember a couple slides ago, Malaysia was quite a bit higher, sitting at 9,500 per person, and so that is a large difference in the amount that's spent on healthcare, on the amount of money that is being generated as GDP for the country. If we look at total health expenditures, they're at about 4.7%, and their total expenditures per capita, 135.20. Malaysia, again, was up at like 455, so they're spending quite a bit less on their healthcare for each person in the country. And then government expenditures as a percent of total health expenditures, a bit lower, 34.3%. So this means that in the Philippines, more out-of-pocket expenditures are going to be occurring because the government is providing less. And their life expectancy also much lower at 68.5 versus the 75 that we saw in Malaysia. If we look at the UHC cube that comes from the WHO for the Philippines and talk about the population in terms of who's covered, we see that the Philippine Health Insurance Corporation has not made it compulsory, and so it covers 91% of the population as of 2016. In 2013, it was amended and expanded to include underprivileged, sick, elderly, persons with disabilities, women, and children. In terms of direct costs, who pays and how this happens, there's no balance billing and or zero copayment scheme for indigents, sponsored senior citizens, and lifetime member groups, but not all government health facilities are designated to serve them and can fully provide the supplies, commodities, and services that they need. And so this is often due to a limited facility budget for operations. So continuing reliance on outside purchases and patients is persistent, and that's why we see these higher out-of-pocket expenditures. In terms of services provided by PhilHealth, they're mainly curative and only benefit inpatients. So the promotive, preventative, and rehab services fall under the jurisdiction of the local government with technical assistance from the Department of Health. And so these two different entities, or really many entities with all the local governments, can allow for some gaps in coverage for patients, especially if you're transitioning from inpatient to outpatient or vice versa. Um, We also know that access remains highly inequitable due to the maldistribution of facilities, health staff, and specialists. So deployment programs are easing these problems a little bit, but the strategies for monitoring and sustaining it persist. The government allocates about 6.5% of funding for disease prevention and control, 14.6% to hospital services, and about 75.4% to technical support services. So if we look at a comparison just briefly, Malaysia, higher GDP, lower population, higher life expectancy, and higher total health expenditures. In the Philippines, we see lower GDP, higher population, lower life expectancy, and lower health expenditures. They are similar in that they both have UHC or on the path towards UHC. Malaysia is a lot further along than the Philippines are. But they also do both have gaps in some of their essential health services and then also high tobacco use, which is an issue. So in terms of the impact, there's a couple of key takeaways from Malaysia that we'd like to highlight. So political and stakeholder support is very important. You need to achieve buy-in from the political party that's in charge and the stakeholders in the community. So if we look back from a historical perspective, when Malaysia gained their autonomy after British colonial rule in the 1950s, public officials were keen to support pathways towards UHC because it was an effective way to visibly benefit the poor Malay citizens, but also garner political support as a result. Also, once moves have been made towards UHC, it's difficult to move backwards. Once you start down the path and gain some inertia towards it, you might not achieve it right away, but there are almost always benefits from this initial momentum. Obviously, one glaring exception is the United States right now, where we've repealed certain aspects of the Affordable Care Act. But in my opinion, and in our opinion as a group, we see that more as a stumbling block towards universal health care rather than completely defeating it. Next point is public and private coexistence. So side-by-side existence allows for diversity of patient choice and also contributes to broader support. Since there weren't mandated changes in the way the private system operated, stakeholder buy-in from hospitals and physician groups remained high, and it got the entire country to kind of rally around the idea of universal health care. It also allows for varying levels of out-of-pocket expenditures and personalized care. So people who like and enjoy the privatized system that they already had are allowed to keep it if so long as they can pay for it. But everyone is still going to receive coverage, whether that's the government or the private sector. In terms of financing, the growing economy in Malaysia allowed the population to pay and support higher taxes to support UHC and other social benefits without compromising on other services. So economic growth stemmed mainly from increased demand to raw materials and industrialization with the intent to export these products, and then that drove up the country's GDP over the last 50 years. And then last, gradual development is better than immediate implementation. So the best models for UHC allow it to grow organically from the system that's already in place, and allows the policies to be fully developed before they're implemented and allows time for pilot projects if need be. So in terms of applicability, we see that the Philippines' path to universal healthcare is full of challenges such as heavy reliance on out-of-pocket payments, fragmentation in health financing, limited financial coverage in health, low absorptive capacity of the Department of Health, and fragmentation in delivery of services, and then, of course, the inequities that persist. With these economic decision criteria and the lessons learned from Malaysia, we know that the Philippines can achieve better health outcomes and health equity. So in summary, the path for both countries to expand UHC should be a multifaceted approach. As GDP grows, both countries should ensure that health system dimensions like financing, service delivery are stable to widen protection for financial risk, and they should ensure that access to quality services and facilities are present. Only then will citizens in both countries receive better health outcomes, responsive health systems, and equitable and sustainable health financing. So we'd like to thank you all for your attention, and we are now open for questions.